So first of all, defining the problem. How accurate is EUS imaging in the differentiation of cystic pancreatic lesions? Is EUS-guided fine needle aspiration sufficient in the differentiation between mucinous and non-mucinous cystic lesions? And are there guidelines that can guide us in the treatment decision? And are there any novel options for tissue acquisition? And what about NCLE? And direction for further research as well. So, background. You know, we see more and more patients with pancreatic cysts. And this is due to more and more high technology imaging. The problem is, whenever we see these patients, what to do with them. So I presume that many of you see these patients, and I think basically some of the patients are not handled at all, and you have a cyst and you do nothing else about that, and others will go into frequent follow-ups. The problem with these patients are, of course, that some of them might turn into malignancy. Others will stay there forever and not create any diseases even through a lifespan. The clinical question is, whenever we see a cyst, is it a benign cyst? Or is it a pre-malignant cyst, or is it even malignant? Is it a benign cyst with a pre-malignant potential? This is not, I don't want to go through all these, but as you can see, there's so many different cysts. Basically, what the question is it a mucinous or is it a non-mucinous cyst? The mucinous cysts, they will develop into, they might develop into a malignant cyst, whereas the non-mucinous, most of these will stay benign. Just for your information as well, IPMN, intramucinous pancreatic mucinous cystic neoplasms, they are in different types. Some of you will say, of course, we knew that before. Others will not know it, so I mentioned it. Gastric type, intestinal type, pancreaticobiliary type, oncocytic type. The reason that I mention this is that they have different malignant, pre-malignant potential. For instance, the gastric type has hardly any malignant potential, whereas the pancreaticobiliary has potential. So it would be nice to know whether a patient with an IPMN had either of these subclassifications. How accurate is EUS in the differentiation between these cysts? You know, serous cyst adenoma, mucinous cyst adenoma, and EUS is very, very accurate at depicting the morphology of these cysts. But how accurate is it in the prediction of the right diagnosis? Here you see a number of cystic tumors. Here, one different cystic tumors. And we might say that this is probably an IPMN or a cystic, mucinous cystic neoplasm. And we might say that this is most probably a multicystic lesion, vascularized, a serous cyst adenoma, most likely, but we can't be sure. That's the problem. We can do EUS-FNA, we can do different kind of tests like CEA, CA99. We can do genetic testing. We can do fluid analysis for mucin and amylase and all these kind of things. And this is part of the evaluation. When you look at the study literature, EUS Then, this is, by the way, this is a mixed type IPMN involving both the main duct and the side branch ducts. But if you look at the studies, this was the first study, and Bill Brookie has done a great work with this to characterize what is the best. And what we saw here was that cytology the accuracy is not very high, whereas CEA, a cutoff of 192, has a better accuracy. This has been confirmed also in systematic reviews. And it dropped even a little more with the sensitivity of about 50%, which is far below acceptance. However, we stick a needle into it and we examine these patients because now and then we get the diagnosis. CEA, a sensitivity of around 63%. So it seems that we need other ways to find the right diagnosis. EUS FNA and IPMN, 64.8% sensitivity. We need better images. We don't have any studies on FNB needles. So most of the studies are done with FNB needles on solid pancreatic tumors. So I can't give you any results on these needles with cystic pancreatic tumors. Are there any guidelines that can guide us in the management of patients with cystic pancreatic neoplasms? There are a lot of guidelines, and you get confused if you're not into really detailed with these guidelines. Sensei guidelines on IPMNs in 2006, Fukuoka guidelines on IPMN in 2012, revised Fukuoka guidelines on IPMN 2017, Japanese guidelines, American guidelines, and recently the European guidelines on pancreatic cystic neoplasm. Note that the former guidelines were all guidelines on IPMN and not on general cystic tumors, whereas the last European guideline is on cystic pancreatic neoplasms in general, but they also go in detail into IPMNs, of course. Revised Fukuoka guidelines, a busy slide, difficult to view, but to bring you quickly through that, then they are talking about high-risk stigmata of malignancy. And whenever there is a high-risk stigmata, then you should undergo surgery. And this is obstructive jaundice. It's enhancing mural nodules more than 5 millimeter in size, and a main pancreatic duct of 10 millimeter. So we are talking about IPMNs. Then there are some worrisome features. This is cyst more than 3 centimeter, enhancing mural nodules below 5 millimeter, thickening or enhancing cyst wall, main duct size between 5 and 9 millimeter, abrupt change in caliber of pancreatic duct with distal pancreatic atrophy, lymphadenopathy, increased serum level of CA19-9, and cyst grow more than 5 millimeter over 2 years. These should either undergo surgery or at least endoscopic ultrasound or MR scan in the follow-up of these patients. The revised Fukuoka guidelines, again, worrisome features and high-risk stigmata. I think it's mainly the same. Cyst size 3 centimeters should undergo, more than 3 should undergo surgery. Then the European evidence-based guideline on IPMN. They are talking about no indication, relative indications, absolute indications, and patients unfit for surgery. But if you look at this, then if there's no indication for surgery, you should do an evaluation every 6 months for the first year, either MRI or EUS, and after 1 year, if there's no progress, then yearly follow-up, EUS or MRI. The absolute indications and relative indications for surgery. The absolute are positive cytology for malignancy, high-grade, the high-grade solid mass, jaundice, enhanced mural nodules more than 5 millimeter, and main pancreatic duct dilatation more than 10. Relative indications, but they stress in patients fit for surgery, one should consider surgery. Growth rate more than 5 millimeter per year. This was in the other guidelines per 2 year. Increased serum level of 19.9. Main pancreatic dilatation between 5 and 9.9. Now the cyst is growing 4 millimeter. And this is because too many patients were offered surgery due to the size criterion. So they added an increase in size before. New onset diabetes, acute pancreatitis caused by IPMN, and enhancing neural nodules up to 5 millimeter in size. These just show the difference. I have skipped that. What also the European guidelines are talking about is contrast harmonic EUS. And they recommend that contrast harmonic EUS should be performed whenever there is a suspicion of a mural nodule. And we can only agree on this because there are some of these nodules that are not really neoplasms. This is just an example. If you look at this patient, look at this. If you see here, there's a mural nodule, and it's most likely a protein plaque. Here you see it. And the other. So what we do is contrast enhanced. There is a mural nodule here, and there is no flow whatsoever in this part. So I think this is something that I think these patients should undergo whenever there is this suspicion, and the patient might go further for surgery. So, oh, sorry, I got out of it. Now, there is also people working on CLE. Okay, I'm sorry, it doesn't work here. But a needle-based CLE, confocal laser endomicroscopy. And people have worked scientifically on this, and there is a very well-characterized study done by these authors. How does serous cyst adenomas look like? How does mucinous cyst adenomas look like? And how does other pancreatitis and so on look like? The studies show that it whenever you see basically what it shows is whenever you see characteristic studies, you're pretty sure. And in particular, serous cyst adenomas, whenever you see these characteristic studies, findings, you can almost certainly be sure that this is serous cyst adenoma. One of the problems is that it is difficult sometimes to see a mucinous cyst and to characterize this. Here the pancreatic cystic neoplasm provided a sensitivity of 59% and a specificity of 100. Look at the complications rate, 9%, mainly pancreatitis. And this has actually, this is the serous cystadenoma. As you can see, it's pretty good for serous cystadenoma, accuracy 87%. And combining EUS FNA plus CLE seems to increase the sensitivity to 90%. Based on European guidelines, there is a major concern about NCLE due to the rate of adverse events, 7 to 9%. And this is something we, of course, have to take into consideration also. Are there any novel options for tissue acquisition? There is this microbiopsy forceps that I shortly mentioned, a biopsy forceps that can pass through a 19-gauge needle, and there are a few studies out there. We have a PhD study ongoing. We have until now at least looked at our first 71 patients with a technical success of about 90%. I don't want to give you big details. We'll show one in a few minutes on live, but you can actually see how it takes and bites the part of the cystic wall. And in most cases, we are able to get samples that can also tell us about subclassification of these cystic lesions. I skipped this for the sake of time. So Thomas shortly mentioned about genomics and proteomics and transcriptomics and all these new things. We're also working on this aspect, and we have to see in the next following years how this will end. Does this help us in the differentiation and classification of these cysts? So this is more of a scientific interest. So coming to my conclusions. Managing patients with pancreatic cyst is complicated due to lack of accurate diagnostic modalities. EUS has an important role in the evaluation and management of cystic pancreatic neoplasms, and FNA is a powerful tool with high diagnostic yield in solid tumors, but it is insufficient in the differentiation of cystic tumors with a sensitivity of around 50%. Experience with new needle designs in solid pancreatic tumors seems promising, but results in cystic pancreatic tumors are lacking. A new method of EUS guided through the needle microbiopsy seems promising for differential diagnosis of cystic neoplasm, and by this method immunohistochemical analysis as well as molecular analysis may be performed, improving cyst classification. Thank you for your attention.